I've gone through number one, the fact that we are going to take, if a patient comes to the accident and emergency unit, that the first thing we are going to do is to take a brief history on what has happened to this patient. And number two, we said we are going to resuscitate the patient. We will resuscitate the patient using the A, B, C, D, E of resuscitation. Then number three, we are going to take detailed history. We're going to take detailed history, and we have mentioned the 5 C's we are going to use to take detailed history from the patient or patient relative if the patient is not conscious. We said number one is the chief complaint. That is what brought the patient to the hospital. And we said number two is the cause, COURSE, which is to try to identify when the problem started. And since the problem started, what has happened? Is it getting worse? Is it getting better? We also want to know all the associated symptoms to that chief complaint. All of the associated symptoms to the chief complaint. And if the patient is not forthcoming with associated symptoms, then we, the health personnel, will try to elicit that by asking questions from head to toe. Example of such question is any headache, any neck pain, any discharge from the ear. You come down to the chest. If the chief complaint is not called for the patient, does not volunteer the cough, you ask the patient or ask the patient relative, is he coughing? Is she coughing? Any chest pain? Then you come to the abdomen, any nausea, vomiting, passage of watery stool. You come to the urinary system, any urinary frequency, urgency. So all of these things are part of the associated symptoms, but you are kind of doing a systemic review to try to pick up if the patient is not coming up with all of those associated symptoms, because every chief complaint has an associated symptoms. Somebody that comes to, let's say, to the accident and emergency unit, and the chief complaint of this patient is headache. Of course, you see, the headache might be associated with other things. Remember that one of the most common presenting symptoms of meningitis, which we'll talk about after some of this class, meningitis, meningoencephalitis, one of the most common presenting symptoms is headache. So you want to be sure that this person is not having a meningitis or meningoencephalitis. So you must add other symptoms that goes with meningitis and meningoencephalitis, such as any neck pain, any fever, any nausea, any vomiting, any blurring of vision. You want to ask all of these things, to rule out meningoencephalitis or meningitis. So all of these things you can go systemically. You can go systemic to try to elicit this information if the patient or patient relative is not releasing them to you. So they are all associated symptoms, and they are part of the cause, COURSE. So the first one is chief complaint. The chief complaint might be headache. So the second C is the cause. When did it happen? What has happened since then? And what are the other associated symptoms to the chief complaint? So after that, you want to look into what is causing this problem. What is causing the problem? If the associated symptoms you have gotten are suggestive that this patient might be having meningitis, so you want to know what is the likely cause, what is the likely risk or risk factor for this meningoencephalitis. So you have to ask the patient, is there any person with similar symptoms around you? Because the person might have, maybe the person might have gone home, maybe the person live at Oyekiti, and the person is from Lagos. And person might have traveled to Lagos to visit maybe a friend. And on getting there, the friend also has headache, also has fever, and staying in a room with the friend for a couple of days. You contract the infection and return back home. So I want to know, is there any history of contact with somebody with a similar problem in the last couple of days to weeks? After that, we also want to know, is there do you live in a crowded place? Is there a military personnel? All these are risk factors for meningitis or meningoencephalitis. So we want to consider all these things. So trying to elicit the risk factor, which we call the cause of this problem, CAUSE. So that is the third C. The first is chief complaint. The second C is the cause. What has happened? Since when has it happened? Chief complaint. What is it? What brought you to the hospital? That's the first C. The second C is when did it start? And is it getting worse? Is it getting better? And then the associated symptoms. So that is the second C, the cause. The third C is the cause. Trying to identify the risk factors for this problem. And the fourth C is the complication. Okay, since this problem started, what has happened? That is the complication. Are there complications that has resulted, are there complications that has occurred because of this problem? So after that fourth C, the fifth C now is the care so far. Okay, since this problem started, have you received any treatment? Were you taken to any hospital before you are being brought to our own hospital? Over there, what did they do for you? So that is the last C, which is the care so far that the patient has received. So other things you also put into consideration is the lifespan, or the lifestyle of this patient. Do you drink alcohol? Do you smoke? Do you use illicit drug? You try to put them into the history. Okay, so that is the detailed history. So after the detailed history, which is the third thing in the line, the first thing we talked about is the brief history. The second thing is resuscitation, A, B, C, D, E of resuscitation. The third thing is the detailed history, which we have summarized using 5C. So, and after that, now we enter into the examination. So we have been able to cover general physical examination, we have covered cardiovascular examination, we have covered respiratory examination, we covered abdominal examination yesterday. So today we are going to be covering the nervous system examination. And after that, after the nervous system examination, we have completed the examination in medicine and pediatrics. So the next thing after that examination is to have a diagnosis. So you now combine the history I've gotten from this patient with the findings you have gotten on the examinations. When you combine these two, you have a diagnosis. So this is what I'm thinking that this patient likely has. And from that diagnosis, that is number one diagnosis. So after that, what you are thinking, you also have other things that it could be, which we call differential diagnosis. Okay, this man is presenting with clinical features that look like a stroke. Yes, it's likely this feature, for example, a person that presents to the hospital, you are thinking person had a history, let's say 6 hours history of inability to move the right part of the body of sudden onset. Say you call the person, Baba, lift your right hand up. He couldn't do it. Baba, lift your left hand up. He's able to raise it up very fast. Baba, lift your right leg up. He couldn't do it. Baba, lift your left leg up. He was able to lift the left leg very fast. And this has started 6 hours ago. Very sudden onset. Person was previously fine. So this is the history, inability to move the right part of the body of sudden onset. And that is the presenting complaint. And the cause now is in the last 6 hours, and it's getting worse. It's getting worse. So you try to rule out other associated symptoms, any headache, any neck pain, any loss of consciousness during the process, any vomiting, or feeling of vomiting. So all these are associated symptoms. So you now come to the risk factors. What is likely the risk factor or the cause of this problem? So are you a non-hypertensive patient? Are you a non-diabetic patient? For how long have you been hypertensive? How long have you been diabetic patient? Do you have any other medical problem? Trying to identify the risk factor. This is the cause, CAUSE. After that, look into complications. Okay, is there anything that has occurred since that 6 hours that this program started? Okay, there's no complication so far. You move to care. So far, okay, in the last 6 hours, did you give? Were you giving any? You're asking relative because the patient might probably be unconscious. Asking relative, did people try to give him anything, maybe give him any medication or any, here, herbal concussion are usually used commonly. Did you give him any herbal concussion or anything? No, we have not given him anything. We just brought him to the hospital. Okay. No, the patient has not gotten any medication, not gotten any care before being brought to our hospital. So this is the history. So what are we dealing with here now? Of course, from the history, is suggesting that this patient had stroke, but we need to do our examinations to be able to confirm that, or at least to be a little bit of sure that this patient is actually having stroke. The stroke happened 6 hours ago. So we'll do general physical examination. After general physical examination, cardiovascular examination, respiratory examination, abdominal examination, nervous system examination. After completing the nervous system examination, we have a diagnosis. So from our nervous system examination is in keeping that this patient has had stroke in the last 6 hours. Okay, fine, it's look like stroke, but there are other things it could be as well. So those other things it could be is what we call differential diagnosis. Most of the time, about two of them is okay. So what else could present like this? Somebody that was previously fine and couldn't move um, uh, uh, any part of the body. There are there are two or three other things it could be. So it could be a case of intracranial hemorrhage, intracranial bleeding as a result of fall, trauma, especially in elderly patients. So you are going to ask, did he fall, any history of fall, to be able to make sure that it is not, it is stroke, not intracranial bleeding as a result of trauma. Intracranial bleeding as a result of trauma. So you're also going to ask this patient, also going to try to identify if there is fever, to be sure that it's not also meningitis or meningoencephalitis, of which in meningoencephalitis, patient might have inability to move maybe one part of the body. So these are the differentials. I have two differentials. Two differentials, but our main diagnosis stands stroke. That is the one we are going to investigate. So after nervous system examination, we now have a diagnosis. So the next thing is to start treatment. We'll start treatment for that thing we have diagnosed. If it's stroke, we have to investigate for stroke and then start treatment. So that is the approach. So let's talk about the nervous system examination here now. So in nervous system examination is probably the most complex part of the examinations, but we'll see how we can be able to make it as simple. So we'll see how we can be able to make this as simple as possible. It's complex, and it comprises a lot of things. But in the hospital, in the accident and emergency unit, we just look at what is the history suggestive of. If the history is suggestive of stroke, for example, we just go ahead and do those examinations, the nervous system examination that will help us to confirm or rule out stroke. If the nervous system is suggestive of Parkinson's disease, then we have another set of examination that we have to do that will help us to either confirm or rule out Parkinson's disease. If the nervous system, if the history is suggestive of cerebellar, because I have cerebrum and cerebellum. Cerebe, cerebrum, the cortex. Then we have the cerebellum, which is the part of the brain that is much more lower down, or the occipital region. So we want to look, is the history suggestive of cerebellar problem? We will do a nervous system examination that corresponds to that one. So it's a little bit complex. So, but we look at what we do in the routine setting, because that's what you are expected to know. What is routinely done? When you say we want to do nervous system examination, what is done routinely? That is what we are going to be looking at today. Okay, so for routine nervous system examination, we have a couple of things we want to do. So, the whole, before I go into the details of it, still follow the same process of grip. I have to greet the patient, hello sir, hello ma. Or if the patient is unconscious, because some of the patients you meet in nervous system with nervous system problem, they will be unconscious. They will be unconscious. So if the patient is unconscious, you greet the patient relative. Hello, sir. Hello, ma. How are you, ma? How are you, sir? You greet, you establish rapport. Grip. 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 You greet the patient or patient relative. You establish rapport. How are you doing? I'm fine, ma. Okay. How is the patient related to you? Oh, he's my dad. Oh, I'm sorry about that. So how's your dad doing? He's there. Oh, no problem. No problem. We're going to do everything possible to see how we can help your dad. So this is rapport. You are trying to establish rapport. You are trying to make the patient. You are trying to make the patient and patient relative comfortable. Please, listen. Can you kindly mute your system so that we won't be having this issue we're having, please? Thank you. Okay, so first thing is, as I was saying before, you greet the patient or patient relative. Good morning, ma. Good morning, sir. So you you establish rapport. Establish rapport by making patient or the patient relative feel more comfortable with you. First of all, ask the patient relative if the patient is unconscious. How is the patient relative related to the patient? Sorry, ma, how are you related to this patient? He's my dad. Oh, sorry about that. So how is he doing? He said, he's there. Okay, I understand. Don't worry, we'll do everything within our power to help him out. So that is establishing rapport. The next thing you are going to do, greeting, rapport, introduction. Okay, I am Paul. I am here to attend to you. I want to examine him now, so that I can be able to ascertain what progress he has made, and then help him more. Okay, so that is introduction. So the next thing is permission. Okay, can you permit me to go ahead? Why not? So you have gotten permission to move on. So that is the grip, the initial approach. That is grip, the initial approach for all the examinations. Okay, so after that, the same process, we have to screen the patient. After I've taken permission, screen the patient, then call in a chaperone if we need to. We call in a chaperone if we need to. So after that, we'll expose the patient. So in this case, we expose the patient, just the chest and the abdomen, and then also expose to the mid thigh. Sorry, covering we expose only the chest and the abdomen. Then we prefer the private part to be covered. But then from the mid thigh lower, we expect to expose those parts. So in other words, we only want to, for a man, the same thing. We want to cover the private part. For a woman, want to cover the private part and then the breast. So we want the hand to be exposed so that we can be able to do motor examinations, do reflexes. We also want the knee to be exposed so that I can be able to also carry out the reflexes, uh, to carry out the reflexes. So that's the exposure. Hmm? As the exposure, make sure that the hands are not with clothes. Also have want the legs not to be with clothes so that we can be able to use our tendon hammer to carry out the reflexes. Okay. So preferable, cover the private part, cover the nipple with a bed sheet or cover cloth or bedspread. Okay, so after the exposure, the same way we'll put the patient in an anatomical position. So when we have done that now, we are set for our examination. So the examination will still follow the same IPPA, inspection, palpation, percussion, auscultation. But here in nervous system examination, again, we are not going to be doing a percussion. We are also not really we are not going to be doing percussion. We are not going to be doing auscultation. We are not going to be doing auscultation. So that's the approach, the general approach for all the examination. But just know the ones that you are not going to be doing in each of the systemic examinations. Okay, so now after that, we're going to inspect. What are we inspecting? We're both going to be inspecting the general appearance of the patient. The general appearance of the patient. So is he looking? Is he acutely ill looking? Is he chronically ill looking? So we look at that. If the patient is acutely ill looking, patient will likely be in some distress. And sometimes those distress will either be respiratory distress, it might also be painful distress. The person is in pain, and maybe as a result of headache, as a result of pain in any part of the body. The person might also be in respiratory distress. So things like that connote acutely. Something is happening acutely. But chronically, the person is completely weak. Person completely weak, inability to do anything. So you try to look their general appearance. After that, you want to look at the patient facial expression. Look at the face. Is there any part of the face that the patient is not moving? Is there any part of is there any part of the face that is deviating to one side? Maybe the mouth deviating to the left side or deviating to the right side. You also want to look at the eyes. Is the one eye more open than the other? So you look at these things. It's telling you have already started to inspect some things that might be going on in this patient. Then after that, the next thing you want to look at on inspection is the general muscle bulk. Is the muscle adequate? Is it enough? Or is it some form of atrophy? Atrophy is when the person has lost muscle. Atrophy might be from a nervous problem, problem itself, causing the muscle to become wasted. Might also be as a result of wasting of the type of wasting we call wasting of disuse. Atrophy, this to disuse. For example, somebody that is chronically ill looking and somebody has been sick, maybe this person have what we call a chronic obstructive pulmonary disease, and the person have not been able to move around. The person have been lying on bed for the last 6 months. So this person doesn't have a nervous system problem. but he has not been using the muscle. So the muscle will become atrophic because of disuse, because the person have not been using the muscle. So this type of atrophy we call atrophy due to disuse. But then the atrophy that is coming from nervous system problem means that the problem is within the nervous system. That is what is causing the muscle to become atrophic. So I want to try to know the muscle bulk. Is it atrophic? Is it normal? And if it is atrophic, is it just in one side or is it generalized atrophy? So these are things we'll look for in inspection. There's also what we call muscle twitching. Muscle twitching is contraction. You see a muscle contracting just in one part of the body, just one separate, might be on the chest, just on the chest. You see it, you see the muscle vibrating. So when you are seeing these things, all these things, we see them on inspection. You see muscle vibrating like this, contracting. We call it muscle twitching. Call it muscle twitching. It can be on the chest. It can be on the forearm. So when we see this, it's kind of telling us some certain things that might be going on in the nervous system. So this is the inspection, what we are looking for in inspection. So after inspection now, the next thing we are going to do in the examination after inspection, the first thing, guys, you guys can take note of this. If you want to write, you can write now, jot them down. The first thing you are going to look for in the routine nervous system examination is what we have done before, what we have touched before when we are doing our resuscitation. That is the level of consciousness. That's the first thing. Is this patient conscious? Is this patient unconscious? That's the first thing after inspection. Yeah? Is the patient conscious? Is the patient unconscious? So after inspection, that's the next thing you are going to do is the level of consciousness. If the patient is conscious, you don't need to go any further. So you are talking with the patient. Hello, sir. The patient responds, yes, sir. How are you, sir? I'm fine, sir. Okay, sir. Please, I want to ask you some questions, sir. Okay, go ahead. Okay, sir, do you know where you are? Yes, sir. I am in the hospital. Which hospital? Okay, health specialist hospital. Okay, so where is health specialist hospital located? It's located at Oyekiti. Fine. This patient is oriented. Patient is oriented in place. Okay, sir. What day of the week is today? Okay, today is Saturday. Oh, that is good. Can you tell me if now if we are in morning, afternoon, or night? Say we are in morning. Patient is oriented first of all in place. So now patient is oriented in time. So one to assess if the patient is oriented in person. Can you identify this person putting on a white in that place? Who is that person? It's a nurse. Okay, who is the person sitting next to you? It's my wife. So the person is oriented in place, time, and person. So this type of person is fully conscious. So you do not need to do any other thing. The patient is oriented in person, time, and place. So using the place the patient is at the moment, where is it? But if you now ask the patient, hello, sir, the patient is in accident and emergency unit at health specialist hospital. You ask the person, hello, sir, where are you? He said, I am in my house. The patient is telling you that this patient is not oriented, is confused. So at that point in time, you now need to move on to do your full GCS. So if patient is not oriented, if patient is confused, you move on to do GCS. Or patient is unconscious, you move on to do GCS. But if this patient is oriented the patient is oriented in a place, time, and person, you move on. Consciousness is full. Is fully conscious. So let's check for other things. The patient is not fully conscious. Patient is not oriented or not conscious at all. Hello, sir. Hello, sir. He's not answering you. Hello, sir, can you hear me? He's not answering you. Then move on. Patient is not conscious. Move on to do your GCS. And we said that GCS, the Glasgow Coma Scale, Glasgow Coma Scale, which we covered uh, in our resuscitation. So just go back if you have not mastered it, you go back and look into it, which we said we are going to be assessing three things: the eye opening, the best verbal response, and the best motor response. We say the lowest score we are going to have is 3, and the highest score we are going to have is 15, which means fully conscious. All right, so if the patient is fully conscious, we just write conscious. If the patient is not fully conscious, we do GCS, and we'll be able to get a number, maybe GCS of 8, maybe GCS of 10, maybe GCS of 9/15. So we'll now write unconscious with GCS of 9/15, or unconscious with GCS of 10/15. Okay, so that is it. So the first thing is level of consciousness. I'm just giving the overall view. We are still going to look at the slide and look at the image. I'm just giving the overall view, overall orientation on what we do on routine nervous system examination. So the first thing you are going to do is to check the level of consciousness. The second thing you are going to do is to check what we call meningeal sign, meningeal irritation. It's coming from meninges. M-E-N-G M-E-N-I-G-E-A-L, meningeal, meningeal sign. So what is the meningeal sign? You want to look at if there is irritation of meningitis. What would that connote? If a patient if a patient is having meningitis or meningoencephalitis, those meningeal signs are going to be positive. We are going to also look at them and talk about them. It's general overview. So that's the second thing. We look at the meningeal sign. So a patient that also has a form of stroke, which we call hemorrhagic stroke. We also cover stroke. Don't worry, guys. We'll talk about stroke. We'll cover stroke as a topic. So when we cover that, we'll be able to differentiate between ischemic and hemorrhagic stroke. When we cover that, we'll be able to, know the difference between ischemic and hemorrhagic stroke. So in a patient that has hemorrhagic stroke, the person will also have meningeal sign. So those meningeal sign will also be positive. So there are two places you are going to have positive meningeal sign. One of them is meningitis and meningoencephalitis. The second one is if there is hemorrhagic stroke, the meningeal signs are going to be positive. So we'll assess for it. The first thing is level of consciousness. The second thing is meningeal signs. So the third thing in that order is the cranial nerves. We're going to look at the cranial nerves. As I'm not sure if you have gotten to this level by now, but there are 12 cranial nerves. There are 12 of them from 1 to 12. So in routine nervous system examination, we don't do all the 12. We just select few of them and do, especially cranial nerve 7. Cranial nerve 7. That is the one we do almost all the time as part of routine nervous system examination. And in some cases, we also do 9 and 10 in patient that has stroke. So those are the ones we do routinely on routine nervous system examination. So you do those cranial nerve, the cranial nerve 7 and cranial nerve 9 and 10. So that is the third thing. The first one is level of consciousness. Second thing is the meningeal sign. Third thing is cranial nerves. So after the cranial nerves, now we're not going to enter into the power, the motor power, what we call the motor power. Enter into the power. We'll also talk about this. We'll assess the power, we assess the tone, and we assess the reflex. So the first thing is level of consciousness. Second thing is the meningeal sign. Third thing is cranial nerve. The fourth thing is motor, the motor power, the tone, and the reflex. So after that, we'll now check the sensation. And for routine nervous system examination, that is where we end it. So the next one we are actually supposed to do, if the patient is conscious, is to check for what we call gait and coordination, just by telling the patient to walk. When the patient is walking, we are trying to see if the patient is atasic, if the patient is falling to one side, if the patient has problem maintaining balance or falling to the other side. So that is where it ends, if the patient is conscious. So number one, let me repeat again. Number one is level of consciousness. Number two is we're going to look for meningeal sign. Number three is we're going to look for if there's any cranial nerve deficit or abnormality. Number four is we're going to look for motor power. We're going to look for motor reflex. We're going to look for motor tone. So after that, we're checking for sensation. And after sensation, we'll now do gait and coordination. So that ends the routine nervous system examination. Okay, fine. Now that I've covered all the steps, let's look at those steps one after the other now. So I have given detail about the consciousness, the level of consciousness, and the GCA. So we're not going to go repeat that again. So the next one we're going to talk about now is the meningeal sign. The first one we have covered it already, level of consciousness. If the patient is conscious and is oriented in person, place, and time, we move on. The patient is confused or unconscious, we do our GCS to name the GCS of 7 or the GCS of 8/15 or 10/15. We'll now document that. So that is it for level of consciousness. So we're now going to the meningeal signs. So there are 3 meningeal signs that we are expected to know. It's very important. There are 3 meningeal signs we are expected to know. Okay, so there are 3 of them. There are 3 meningeal signs. One is what we call neck stiffness. Neck stiffness. Neck stiffness. Number 2 is, as we are seeing in this picture, is the Koenig sign. Number 2 is the Koenig sign. Number 3 is the Brudzinski. Number 3 is the Brudzinski. So those are the 3 meningeal signs. So that's the second thing we do in routine nervous system examination. So what is neck stiffness? Neck stiffness, as we are seeing in this patient that is labeled, the little boy that's labeled Brudzinski's the Brudzinski neck sign. Neck stiffness is that in a normal person, when you try to flex the neck, you just put your two palm under the occipital region of the patient head, and you just try to flex it. Just try to flex it. Patient is like this. You put your hand at the back of the patient neck and just flex it. So in a normal person, if you just flex this neck like this, is supple, is supple or soft. It's supple or soft. So my neck is moving freely. As I'm flexing it, it has a smooth movement. But in patients with neck stiffness, when you try to do that, it is rigid. It is very hard. The neck cannot be able to flex. The neck cannot be able to flex. You are putting your hand at the occipital region of the patient head, and you are trying to flex it, but it's very strong. It's rigid. You can't be able to flex that neck. It's a typical sign you see in meningoencephalitis and meningitis, and in patients with hemorrhagic stroke, as I've mentioned before. So that is neck stiffness. It can't move. You try to flex the neck, by putting a little force at the back of the head, trying to flex it, but you encounter resistance. The neck could not move. So when a patient have that, we said there is neck stiffness. That's neck stiffness. So after neck stiffness, the next thing you are expected to do is the Brzezinski. So the same way, the same time you are doing neck stiffness, you are also doing Brzezinski. You can see what the picture is showing in Brzezinski sign. Patient has put a hand at the back of the patient uh, head, that, trying to flex that neck. So at the same time, you are encountering that resistance from flexing the neck. The patient pull the lower limb towards the abdomen. So you can see there's flexion at the um, there's flexion at the thigh and there's flexion at the knee. Hmm? So what is happening at this point is the fact that when you try to flex this neck, the person is having irritation of the meninges. Patient having irritation of the meninges, which is the covering of the brain and the spinal cord. So the meningeal sheath is kind of a soft sheet that is covering the brain and the spinal cord. So during inflammation or a blood irritating those meninges, if you try to flex the neck, you have more irritation of the meninges. So that irritation will cause pain along the spinal cord. So in order for the patient not to feel much pain, the patient unconsciously flex the thigh and the knee in order to resist the pain. Patient is feeling pain and he will unconsciously flex the thigh and the knee just to make the pain to become less. So when you have that, as you are flexing the neck, the patient is flexing the thigh and the knee. We said that is positive Brzezinski sign. That's positive Brzezinski sign. So you can see it's in the lower image, Brzezinski sign, neck flexion leads to knee flexion. So both flexion at the knee and flexion at the thigh. So it's because of irritation of the meninges, which are the soft sheet covering the brain and the spinal cord. So the person will unconsciously flex the knee and the thigh in order to prevent more pain from occurring. So after Brzezinski sign, we now have the Koenig sign. So what do we do in Koenig sign and how do we do the Koenig sign? Look in this image. In Koenig sign, first of all, what we try to do is we would flex one of the lower limb. We'll flex as it's being done in this place at the thigh, at the pelvic joint. We'll flex it. We raise it up. So when we raise it up, look at the nail. The nail is still extended in this picture. Sorry, the nail is still flexed in this picture. So we have flexed at the thigh. We have also flexed at the knee. So what we're trying to do here now, as we are flexed at the knee, we'll try to extend the knee. Try to extend the knee. So once the knee, that needs to become straight instead of bent, the way it has bent in this picture. We'll try to make it to become straight, to extend it. But when there is Koenig sign, when Koenig sign is positive, the person will resist that extension. Why? Because of pain as well. So the patient will feel pain and will resist you extending the knee. Patient will resist you extending the knee. So you will not be able to get a full straight knee. The knee will continue bent. Patient will resist you from flexing the knee. So when you have that, we say that the Koenig sign is positive. That's positive Koenig sign. So this man now, as we have seen here, is trying to, in the first image here, the health personnel is trying to flex. First of all, he has flex at the thigh. That's the first thing. You can see that the left leg, the left lower limb is straight, but him, he has now flexed the right lower limb at the thigh. He has also flexed the knee, the same right knee. But what he's trying to do now is to extend that right knee, try to make it to become straight. But a patient with Koenig sign will not permit that because of pain. The person will be having severe pain that the person will resist that right knee from being extended. So when we have this, we say that's positive Koenig sign. So let me take question here before I move on, because this meningeal sign is important. It's important to get the basic principle of knowledge. So let me hold on a little bit and take questions. So the three meningeal sign, neck stiffness, Brzezinski sign, and Koenig sign. Let's take questions, guys, before we proceed. If you don't have question, just type there's no question so that we'll move on. Guys, if you don't have question, type there's no question so that we can move on. Okay, if you can hear me, indicate that you can hear me. You can type. You can type. Just type. You can hear me so that I will know that you can hear me. So I will move. All right. So no question. We'll move on. Okay. So we are done with we said the first thing we're going to do in nervous system examination is the level of consciousness. We are done with level of consciousness, right? To ascertain if the patient is conscious or the new patient is not conscious, we check for GCS. We have done that. We have covered the meningeal signs. We said there are three of them: the neck stiffness, the Brzezinski sign, and the Koenig sign. So after that, the next thing we are going to look at is the cranial nerves. And I said routinely, what we do routinely is cranial nerve 7, 9, and 10. So let's look at the cranial nerve. Look at those cranial nerves. But before I proceed, you can see that what the picture we're having here is some of the pictures we use in nervous system examination, and that is tendon hammer. That is the one that is very applicable to the routine examination, is the tendon hammer. So at the left-hand side, we're having ophthalmoscope at the left-hand side, and here we have the turning fork, and here we have the cutting board, then the tendon hammers and pin. So I've covered the level of consciousness. We have covered the meningeal sign. So let's look at the cranial nerves. So this slide is detailed, presenting the all the cranial nerves. But like I've said before, we don't routinely do them on nervous system examination. So what we do is cranial nerve 7. Let's look at cranial nerve 7. So cranial nerve 7 is the facial nerve. Cranial nerve 7 is the facial nerve. So the first thing we do for the facial nerve is, first of all, we will look at the patient from inspection. We look at the patient from inspection. If there is from inspection, if there is if there is deviation of the angle of the mouth towards any side, the angle of the mouth can be deviated towards the mouth, towards the left. It can be deviated towards the right. So when we look at the angle of the mouth, if it is deviated or not, the next thing we are going to look at is the groove between the nose and the mouth. This groove, let me put my distance so I can just use myself to. That's the groove here. This groove here. So angle of the mouth can be deviated towards one side, towards the other side. So that's the first thing you're going to look at. That's the first thing you're going to look for in inspection. Is it deviation of angle of the mouth towards any side? Hmm? So after that, you are going to look for this groove, the groove here. If the groove is still there or if the groove has disappeared. Remember, you're comparing the groove here with the groove at this side. So in somebody that is having a facial nerve defect, the groove at that side will disappear. The groove at that side will disappear. And then the angle of the mouth will deviate. The angle of the mouth will deviate. So the angle of mouth will deviate to the side of the lesion, to deviate to the side of the lesion. So after that, the next thing you want to do is, if the patient can be able to wrinkle the forehead. I'm trying to do that now, but I'm not sure if I know. Okay, wrinkle the forehead. If the patient can be able to wrinkle the forehead, just tell the patient to look up. If the patient is looking up, the patient is trying to wrinkle the forehead. But let me bring the picture from the class actually. So if the patient can be, look at in the first image, that's what this first image here by the right, the first image by the right. I told the patient, try to look up. Patient is kind of looking up, thereby wrinkling the forehead. You can see the forehead wrinkled in this picture. So in any patient with facial nerve defect, the person will not be able to wrinkle the forehead at the side with the lesion. Person will not be able to wrinkle the forehead at the side with the lesion. But this man now that they are presented in this image, at this our left hand side, at this our left hand side, is completely fine. It's able. We are looking now. The mouth is not deviated to any side, and the nasolabial groove, which I have shown you here, the groove between the nose and the mouth, nasolabial, labial, mouth, Naso, nose. Nasolabial groove. That groove is still maintained. You can see that it is symmetry. It's the same on both sides. So the groove is preserved. There's no deviation of the angle of the mouth, and the man is able to wrinkle his forehead. So it's completely fine. There's no facial nerve deficit in this patient. But then if there's any deviation, if the deviation of the angle of the mouth towards the side, towards one side, and the disappearance of the nasolabial groove, and the patient will not be able to wrinkle the forehead, that is cranial nerve deficit. First of all, I want you to also know what is the function of the cranial nerve. What function of the cranial nerve 7, facial nerve. The facial nerve is responsible for the muscles of the face. It innervates the muscles of the face. So those nerves within those muscles within the face are innervated by the facial nerve. So again, now when we look at this image in the right side, what they have told this patient is to try to close the eyes. Patient will close the close the eye very tight. And patient close the eye very tight, you try to use your index finger to pull at the upper eyelid, pull the upper eyelid up. So any patient with intact facial nerve, you won't be able to open the eyes. But any patient with facial nerve weakness, you just open it. The person will not even be able to close the eyes. The eyes will remain open. You tell the person close the eyes. So the eyes in that part of the face that has the problem, the eyes will not close. The other one will close. The side with problem will remain open. So tell the patient to close the eyes and try to pull at the upper lid, trying to open the eyes. In a patient with intact facial nerve, you will not be able. You will not be able to. You will not be able to open the eyes. So the next thing is tell the patient to puff the lip, puff out the lip, as we are seeing in the image down. So a patient with facial nerve will also not be able to, because the person will not be able to close the mouth. Look, puff the lip. Close the eyes. Close it tight. Don't allow me to open it. So a patient with facial nerve deficit will not even be able to close the eyes. One eyes will, the normal side will close. The eyes on the normal side will close. The eye on the side of the face with lesion will remain open. Will not be able to close the eyes on that side with lesion. Then you tell the patient to puff the lip. Patient with facial nerve defect will not be able to puff it. When the patient wants to do it, air will escape. Puff the lip. But in a patient without facial nerve, puff the lip. So first, in the facial nerve examination, the first thing is inspection. You look if there's any deviation of the angle of the mouth to any part. It's deviated. So as it's deviated, look at this. It's lost. As my mouth is deviating to, let's see now. So my mouth is deviating to the right side, and there's loss of this groove, the nasolabial groove. So it means that the facial nerve on this side, on the left side, is weak. The facial nerve on the left side is weak. So my mouth is deviating towards the right side. My mouth is deviating to the right side. The facial nerve on the left is weak. and there's loss of nasolabial groove on the left side. So now when I'm told to wrinkle my forehead, I'm trying to do that, but I'm having problem here. Wrinkle the forehead. I'll not be able to wrinkle here because the facial nerve on this side is defective. I'll not be able to wrinkle. I'm not able to wrinkle the forehead. So number one, mouth deviation. Number two, loss of nasolabial groove. Number three, inability to wrinkle the forehead. Number four, inability to close the eyes completely. And number five, inability to puff the lip. So those are signs of facial nerve deficit. Where are they going to be positive? Of course, in a patient with stroke, and then a patient with other problem that has to do with facial nerve like Bell's palsy, which for now, if time permits, we might cover it. We'll call Bell's palsy. But the typical sign where you're going to pick this facial nerve deficit is stroke. Somebody's coming in emergency unit, conscious. When you want to look at is the face. Want to look at the face. Is there deviation of the angle of the mouth? Is there any loss of nasolabial groove? So that you can be able to ascertain if it's stroke, patient is likely going to have that facial nerve deficit. Okay. So after that, another cranial nerve that we check, especially in patients with stroke, is cranial nerve 9 and 10 by doing what we call swallowing reflex. By doing what we call swallowing reflex. How do we do swallowing reflex? Before we do swallowing reflex, you must make sure that the patient is conscious. Please don't go and do swallowing reflex in a patient that is not conscious. So how do we do the swallowing reflex? We just want to know if the patient can be able to maintain what we call gag reflex. We mentioned gag reflex sometimes when we are doing resuscitation. Remember, we say gag reflex is the possibility that if something touches the upper part of throat, if I use my spoon or something and touch the upper part of throat in a patient that is fully conscious, it will irritate. The person will have that sensation of choking and irritation. So gag reflex. So I want to know if the patient gag reflex is intact or not. If the patient gag reflex is intact or not, and if the patient can be able to feed. So we do that in a patient with stroke. To put a spoon, let's say this is a spoon, like this is a spoon, and you put a water on the spoon and give it, tell the patient to open the mouth. Patient will open the mouth. You pour the water on the patient, inside the patient's mouth, and tell the patient to close the mouth. The patient should not swallow. The patient will close the mouth with the water. Now you tell the patient, after some few seconds, allow the patient to settle, maybe 4 seconds, 5 seconds. You now tell the patient to swallow the water. The patient will swallow the water. If the patient is swallowing the water, if the patient starts to cough, if the patient starts to cough and choke, it means that the patient's swallowing reflex is not intact. The patient's swallowing reflex is not intact. It means that instead of this water entering into the esophagus and into the stomach, the water has entered into the trachea and into the lungs, thereby provoking cough, making the patient to cough. So it means that this patient's swallowing reflex is not intact. So we'll do that 3 times. Pour water in a spoon, tell the patient to open mouth, pour the water inside the patient's mouth, tell the patient to close the mouth. After 5 seconds, tell the patient to swallow the water. If the patient swallow the water and the patient start to cough, patient start to be irritated, or patient start to choke, it means that this patient's swallowing reflex is not intact. So we need 2 out of 3. If the patient pass 2, There's no coughing, there's no irritation, there's no choking for 2 times out of 3. It means that the patient can still be able to tolerate food. Patient swallowing reflex is intact. But if the patient is not able, the patient, 2 out of that 3, the patient was choking, the patient was coughing, it means that the patient's swallowing reflex is not intact. The patient's swallowing reflex is not intact. So you should never feed that patient. Don't feed the patient. The patient will aspirate. The patient will become hypoxic, and the patient might die from that. So be careful. Don't go and start feeding a patient with stroke so that you don't kill the patient. So that you don't kill the patient. You must do swallowing reflex. 3 times with spoon, feed with water, swallow it 3 times. If the patient is able to pass that, swallow without coughing, without choking, we say that the swallowing reflex is intact. We can go ahead and feed that patient. Okay, so what we check is swallowing reflex. What we should know that what mediates swallowing is cranial nerve 9 and 10. They are the cranial nerve that control the swallowing. The glossopharyngeal nerve and the vagus nerve, that are the nerves that control all this, the ability of epiglottis to close, and the closing up the trachea, opening up the esophagus for the food and water to enter into the esophagus. That action is mediated by cranial nerve 9 and 10. So when we are doing swallowing reflex, we are checking for the intactness of cranial nerve 9 and 10. So those are the ones we check generally on examinations, cranial nerve 7 and cranial nerve 9 and 10. Okay, so cranial nerve 7, 9, and 10, those are the ones we check on routine nervous system examination. So we have covered one, we have covered level of consciousness. Number 2, we have covered meningeal sign. Number 3, we have covered the 3 cranial nerves we routinely do on nervous system examination. So number 4 now is the motto. First of all, guys, I guess you guys know what a motto is. If you don't know what a motto is, please tell me. Okay. On nervous system, we have motor and we have sensory. Motor and sensory. We have motor, sensory, motor, sensory, motor, sensory. So motor is the ability to move the muscles, the activities of the muscles. I'm moving this my hand. I'm moving this my hand. That is motor action. Is the muscle. When we talk about muscle, we are talking about, when we talk about motor, we are talking about muscle activity, the ability to move the muscles. And that is motor. When we talk about sensory, we are talking about sensation, the sensation on the skin, the sensation on the skin. We're talking about the sensation that the patient is speaking on the skin. So after cranial nerves examination, the next thing is motor, the motor activity. How do we do motor activity? The motor activity has 3 parts. So the first part is the power. The first part is power. The second part is reflex, and the third part is tone. Power, reflex, and tone. Power, reflex, and tone. Power, reflex, and tone. Or power, tone, and reflex, sorry, in that fashion. Power, tone, and reflex. Power, tone, and reflex. So we do it in that order. We do for power, we do for tone, and we do for reflex. So how do we assess for power? Guys, remember, I don't want you guys to be confused. At the beginning part of this class, I told you that nervous system examination is a little complex. But what we're trying to do is to make it as easy as possible. I understand you guys will say this is a lot of stuff for us. I'm trying to make it as simple as possible. We have power in GCS. When we're talking about GCS examination, we have power there, and that power we said is the power of we'll tell the patient to raise the hand up, and if the patient raises the hand up, we said the patient has a power of 6. Patient obey command. Patient has power of 6. If the patient is not able to obey command, we say we are going to put pressure, or put pain on the chest, rub the chest very well to put pain or pressure on that patient's chest. So if the patient is able to localize the pain, we say the power is 5. If the patient withdraw from the pain, we say the power is 4. Like that. That's how we assess power in GCS. The power in motor examination is different. It's not the same power. The power in motor examination is not the same power. The power in this motor examination is assessed differently. So the power in this motor examination, what you will do is you will tell the patient, you tell the patient to move, to raise the leg up. So that's the first thing you assess. You tell the patient to raise the leg up. The patient is not able to raise the leg up, you tell the patient to raise the hand up. So you do that for both the right lower limb, the right upper limb, the left lower limb, and the left upper limb, telling the patient to raise them up one after the other. If the patient is not able to raise the leg up at all, or if the patient raise the leg up, let's say you are the person, the head attendant, the head personnel attending to me. So, and I'm your patient, you tell me I should raise my hand up. I am lying flat on bed with my hand at the bed. You now tell me to raise my hand up. I raise this hand up. I'm able to raise it up. So if I'm able to raise it up, the next thing you are going to do, you try to put your hand on this, my hand. You try to put your hand here and push it down. As you're trying to push this hand down, you're trying to push it. I've raised it up. You're trying to push it, but I'm resisting. You push. I'm resisting you pushing this hand. If I'm able to resist you pushing my hand down, that means I have a full power, the power of 5. Remember that power in GCS is rated 6. The highest power there is 6. But the power in motor, the power in this motor we are talking about here, which is the power to assess for the power when we're assessing motor, tone, and reflex. The highest power here is 5. The highest power in GCS is 6. The highest power in GCS is 6. The highest power in this one, the power, tone, and reflex, the highest power is 5. So if I'm able to raise my hand up and you are pushing my hand down and you are not able to push it because I have much power trying to resist you pushing it down, if I can maintain that, then I have a power of 5. I have a power of 5. But if I raise this, I'm able to raise this hand up, then you push it and my hand fall down. I raise it up and you push, my hand fall down. That means I don't have enough power to resist you pushing it down. I don't have enough power to resist you pushing it down. If I don't have enough power to resist you pushing it down, so I raised it, I was able to raise it up, you push it and my hand fall down. That means I have a power of 4. I have a power of 4. You tell me to raise this hand up. I try to raise it. 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 I try to raise it a little bit, but you have to fall down again without you applying any force. Look, raise. You told me, sir, raise your right hand. Raise your right hand up. I try to raise it. I try to raise it. I try to raise it, but it will fall down. I try to raise it. It fall down. I'm not able to maintain it. I'm struggling. I raise it. I'm not able to maintain it. It fall down without you applying any force to bring it down. When that is happening, then the power I have is 3. The power I have is 3. Look, I'm lying on bed and my hand is placed. My hand is placed like this. This is my hand on the bed. Let's use this table as a bed. My hand is placed on the bed. You tell me to raise my hand. So I raise your right hand. I try, but it will fall down. I try again, it fall down. I try, it fall down. The power is 3. The power is 3. But let's say you tell me to raise my hand, raise this my hand. So raise your hand. I'm not able to raise my hand. Raise your hand. I'm not able to raise my hand, but I'm able to move it horizontally on the table. I'm able to move it horizontally. I'm not able to raise it up. I can't raise it up, but I can move it. When I can do this, the power is 2. The power is 2. But you tell me to move the hand or raise it. I'm not able to do that. I'm not able to do that at all. I'm not able to do that, but I can be able to move only the toes. There's no horizontal movement at all. No horizontal movement. Only the toes are moving. So this is a power of 1. It's a power of 1. So we call this flicker of movement. This is what we call flicker. F-L-I-C-K-E-R, flicker. Flicker of movement, just small movement. Flicker of movement. There's no movement at all. So move your hand. Raise your hand up. I couldn't raise it. Nothing is moving at all. The power is 0. The power is 0. I can't move at all. Flicker of movement. 1, horizontal movement. 2, I move up, I can't retain it. I move up, I can't retain it. 3, I'm able to move up, but you apply small force, my hand fall down. 4, I'm able to move it, you apply force, I'm still holding it. You're applying force, I'm still holding it. 5. So what do we need to take note of here in this class? Differentiating this power from the power of GCS. The power of GCS ranges from 1 to 6. The power in this power tone and reflex ranges from 0 to 5. 0, no movement at all. 0, no movement at all. 1, flicker of movement. Flicker of movement. Only the digits are moving. Flicker of movement. Only the digits are moving in 1. In 2, horizontal movement. Only horizontal movement is permitted. 3, I'm able to raise it up, but then the gravity, the force of gravity will fall it down. I'm not able to keep it against the force of gravity. I'm not able to keep it against the force of gravity. That is 3. Number 4, power of 4. I'm able to raise it against the force of gravity, but when you put small force, when you put more pressure, it falls down. Number 5, I'm able to raise it strong, and you are pushing it. I'm holding it. You can't bring it down. That is 5. So the power here is graded from 0 to 5. Unlike the power in GCS, which is graded from 1 to 6. So that is our power. That's how we are going to assess our power. How do you assess our tone? The tone is a little bit straightforward. What you are looking at is the joint. You move the joint, you move the joint. You can start from the small joint, this small joint, you move them. Comparing the two sides, you move at the wrist, flex, extend, flex, extend, flex, extend. You also flex here, extend, flex, extend, flex, extend. What are you doing? You are comparing the resistance here with the resistance here. Comparing the resistance here with the resistance here. So if as you are moving here, this is rigid, it's solid, you are not able to move it. You are not able to move it, but you are moving here, you are moving this one freely. We say there is hypertonia in this place. There's hypertonia. So it's rigid. You can't move it freely. It's not free. It's not free. So there's hypertonia. This one is normal tone. This side is normal tone. But the tone can also be hypotonia. Tone can also be hypotonia. When you try to move it, it just falls. Any little thing you do, it falls. It falls. Any little thing you do, it falls compared to this one, which is normal. When you have that, you say that is hypotonia. So the tone can be normal, it can be hypotonia, or it can be hypertonia. Normal tone, hypotonia or hypertonia, just by moving the joints to see if the joints are stiff, if they are strong, there's resistance in the joint, or if it is flaccid. As you are doing it, it just falls. As you move it, it just falls. So the same thing goes to all the joints. You check this joint, the elbow joint. You check the elbow joint, checking how weak or how resistance is in the elbow joint. The same on this side. So you do that on the shoulder as well. You do that on the hip joint, and you do that on the knee, comparing the two sides, as well as the ankle. So when you do this, you're going to have either normal tone, hypotonia, or hypertonia. So that's how we check for the tones. So the next one is the reflex. We are seeing the tendon hammer that I showed you earlier. So you use the tendon hammer. You use the tendon hammer and you check for reflexes. The biceps, the triceps, check the knee. So the tone can also be, the reflex can also be, it can be normal reflex. It can be hyporeflexia, or it can also be hyperreflexia, just as we have on tone. Normal reflex, hyporeflexia, or hyperreflexia. So one thing you must take note in this class is that the tone and the power move on the same side. So if you have hypotonia, you will also have hyporeflexia. If you have hypertonia, you will also have hyperreflexia. So the tone and the power move in the same direction. Hypotonia, hyporeflexia, hypertonia, hyperreflexia, they move in the same direction. So we're also going to look at the class. I'm just showing demonstration on this. So the next thing we are going to do after this tone, after this power, tone, and reflex is the sensation. How do we check for sensation? We use cotton wool. When you take a cotton wool, a small cotton wool, you just touch it on the patient body with the patient eye open. You touch it on the patient body with the patient eye open. You tell the patient, if the patient has taken note on how it feels, the patient will tell you yes. But you do this sensation in a patient that is conscious. You also do We also assess for power in this power, tone, and reflex. In a patient that is conscious, in a patient that is not conscious, you are not going to do power, you are not going to do power, you are not going to do sensation. You can only do tone and reflex. So that is the difference. You must take note of this, because in a patient who is not conscious, the patient will not obey command. Raise the hand up. How will a patient that is not conscious raise the hand up? And for you to assess this power, you need the patient to obey command. Remember, in power in the GCS, if the patient is not, if the patient can't obey command, you put pressure. But here, all we need is the patient to obey command in this power. If the patient cannot obey command, you don't assess for this power here. You only assess for tone and reflex, and you don't assess for sensation if the patient is not conscious, because you want to give the patient instruction to follow. So you use the cotton wool. Patient eye open, you touch the patient, you touch the cotton wool on the patient's skin. So did you see how it feels? Yes. Okay, now close your eyes. The patient will close the eyes. So you use the cotton wool. You tell the patient, if you feel it, say yes. As the eye is closed, so you touch on the thigh. The patient didn't say anything. You touch on the thigh here. The patient said yes. You touch on the chest. Patient didn't say anything. You touch on the chest here. Patient say yes. You touch on the thigh on the left side. The patient didn't say anything. You touch on the thigh on the right side. Patient say yes. It means there is loss of sensation on the left side of the body. There are lots of sensation on the left side of the body. So the next one we are going to do is that gait and coordination I told you about. So tell the patient to stand up from the bed and walk. Then stand up on the bed and walk. So if the patient is swinging, falling to one side, or the movement is not smooth, we say the patient is atasic, or there's gait problem, there's gait abnormality. So that completes the nervous system examination. Now let's look at the slide and what if there's any additional thing we have missed out. So the cranial nerve 7 that we have talked about. The cranial nerve 9 and 10, which is glossopharyngeal nerve and the vagus nerve. Swallowing, coughing, gag reflex. Okay, so motor examination, the bulk, muscle bulk, which I told you, you have to look at if there's atrophy or not. If there's atrophy or not. So the strength, which is the same thing as the power. Okay, this is the grading I told you of. Guys, just look at it, please. It's different from the power in GCS. You can see that the power here is graded from 0 to 5. 0 to 5. 0, no movement. 0, there's no movement. 1, there's only what we call flicker of movement. Only the digits are moving. Only the digits are moving. So 2 is just movement, horizontal movement. The patient cannot move against the force of gravity. The patient cannot move against the force of gravity, just horizontal movement. So number 3 is the patient can be able to move it against the gravity, can be able to raise the hand up or raise the leg up, but it will fall. It will fall on its own. It will fall on its own without putting any force, any resistance to bring it down. So 4 is you raise, patient raise it up, but when you apply any little force, it will fall down. Patient is not able to resist any force you are putting on that hand or the leg. And 5, there is full power. So patient raise the hand up, you try to press it down, nothing. Patient is still holding it there. So remember that in a patient with stroke, the power can be either 0, it can be 1, it can be 2, It can be 3, it can be 4 on that affected side. Let's say it's the right side of the body that is affected. So the power on the right side of the body can be 0, 0 on the right upper limb, 0 on the left upper limb, or 1 or 2 or 3 or 4, but it will not be 5. If it's 5, it is not stroke. A patient with stroke cannot have a full power. So the power will be less on that affected part of the body. So these are just the reflexes that we talked about. The tendon hammer, you are going to use the tendon hammer. You're going to use the tendon hammer. You see how this man is putting his left thumb at the elbow joint, at the anterior aspect of the elbow joint. So in that, where his left thumb is, he's going to use a tendon hammer and strike on top of that his thumb. If you strike it and the hand jump up, if you strike it and the hand jump up, you see a movement, a sharp movement, jumping or sharp movement on the hand. It means there's hyperreflexia. But if you strike it and there's some movement, not jerky movement, just some movement, then the reflex is normal. If you strike it and nothing at all, it means there's hyporeflexia. There's hyporeflexia. There's hyporeflexia. And the same thing goes on these ones. Checking for the reflexes. Okay. So this one is plantar reflex. Well, is also done, but not routinely done. Plantar reflex is not routinely done. So for your level, don't get really worried about plantar reflex for your level for now. With time, as we go deep, you can understand, but just master these few ones. It seems a lot for now. It seems a lot of stuff for now. Just master these basics, and later on you can go ahead to learn more advanced stuffs. So master the basic things in the nervous system examination. So what are those basic things again? Let's repeat those basic things again. Number 1 is level of consciousness. Conscious, unconscious. Conscious, we don't need to do any other thing. Unconscious or altered level of consciousness, we do GCS. So we can know if the power is 9, if it is 10, if it is 8. So after that, after consciousness, the next thing we are going to do is meningeal signs. And we said there are 3 meningeal signs: neck stiffness, Brudzinski sign, Koenig sign. So after that, we do the cranial nerve, which we have said, the facial nerve, which is cranial nerve 7, and the swallowing reflex, which we assess for cranial nerve 9 and 10. So after that, now we assess for our power, the motor power. We assess for the motor power, which will grade here from 0 to 5. So after assessing for power, we assess for tone just by checking at the joint. After assessing for tone, we now assess for reflex. After assessing for reflex, we'll check sensation using a cotton wool to touch. After that, we now check for gait and coordination, and that completes nervous system examination. Please, let's ask question now. I know it's a lot of stuff. I told you guys that nervous system examination is the most complex of all the systemic examinations. So put in the chat box question, clarification. If you don't have any, you say you don't have, so that we can take break. We'll come back. The next class won't take much. Within 20 to 30 minutes, we are done. That will complete all the things we have been talking about in the last how many days. Just the how to formulate diagnosis and how to do initial investigation and management. Guys, if you don't have question, please tap in the box. If you can hear me, tap in the box so that we'll take break. Take break of 15 minutes. Okay, if you can hear me, just say you can hear me so that we can go. Okay, that is fine. You can hear me fine. Okay, so let's take.
Can hear you, sir.
Okay, so fine, that's good. Let's take 15 minutes break. If we take 15 minutes break, we'll come back. We'll spend like next 30 minutes just to formulate our diagnosis and then the initial management, and that is it. That will conclude our how to attend to a patient in emergency, in accident emergency unit. So it will take 15 minutes now. So we'll come back, we'll just round up with that. After we round up with that, the next class we are going to have, I want to lecture you guys on the cardiopulmonary resuscitation itself, CPR, so that if a patient comes to accident and emergency unit, the patient is unconscious, the patient is gasping, the patient is dying, you can know the approach for cardiopulmonary resuscitation, the so-called basic life support. The basic life support, cardiopulmonary resuscitation. We'll talk about that. After that, we will now have to pick all the common emergency medicine. We'll talk about how the patient will present, what are the symptoms that the patient will have, the diagnosis, and the differentials. That is the things that will present similar way. The things that will present similar way. How the investigations to do in those emergency situations and how to start the initial management in those patients. So our subsequent class, that's what we'll be talking about. Because we have gotten the basic knowledge we need now, which is this sequence of attending to a patient that presents to the accident and emergency unit. So after this one, we are going to talk about basic life support, cardiopulmonary resuscitation. So that if a patient, they are bringing patient in, the patient is gasping for air, the patient is dying, how you can recognize this, that this patient is gasping for air, the patient is dying, so that I can start your 3 basic investigations. There are 3 basic investigations that we must do in any patient that presents to the accident and the emergency unit. So any patient that presents to the accident and the emergency unit, after going through the sequence of attending to the patient, the sequence of brief history, the sequence of after brief history, resuscitation, using the ABCD of resuscitation, taking detailed history, using the 5 C's that I've talked about, do our examinations from general physical examination to nervous system examination. After that, we'll arrive at a diagnosis. After we have arrived at a diagnosis, we'll now have to investigate the patient. Remember that in our in the resuscitation class, we said in the C part of the resuscitation, in the C part of the resuscitation, which is the circulation, that we need to set up an IV line. We said after setting up an IV line, we need to take sample
for investigations. After taking sample for investigation, we need to give the initial medication that the patient needs. If the patient is in pain, we give the patient pain relieving medication. So that sample we are taking at that point, this investigation we are talking about is part of that sample. So the sample we are taking at that point in time, at that particular point in time when we are resuscitating this patient, is one we call the basic investigations, the routine investigation. So in all the diseases, no matter what your diagnosis is, you must send sample for those three things. One, you take sample for full blood count. Two, you take sample for urinalysis. Three, you take sample for electrolyte, urea, and creatinine, which is kidney function test. Those are the three things. So you must take, you take that blood you are taking at that time you are doing the circulation, you are doing your resuscitation, you take sample in the C part of resuscitation, the circulation, you take sample for investigations. So the investigations that we are ordering at that point in time will include the full blood count, where we assess for the patient PCV, assess for the patient white blood count, assess for the patient platelet. So we do full blood count. So the sample we are taking, we are going to do full blood count with that blood sample. We are going to do electrolyte, urea, and creatinine. That is checking for kidney function. Then we are going to take urine sample to do urinalysis. So those three are basic. We must do them in any patient that presents to the accident and emergency unit, no matter what the diagnosis would be. But in the private hospitals, we are a little bit careful. When a patient comes in, we don't usually write all the three. We try to look at the patient pocket. Can the patient be able to afford these three investigations? So if the patient cannot be able to afford it, we just manage the patient based on our findings on the history and examination. We just move ahead and manage the patient based on that in the private hospital. But in private hospital, patients are managed according to how they can afford the service. So you can start writing EUCR that is around more than 10,000 naira now for a patient who has presented to a private hospital, maybe with a gastric pain, maybe as gastric pain suggestive of peptic ulcer. So if you write full blood count, if you write EUCR, for example, which is around 10,000 for that patient, the patient might not be able to afford it. The patient might not be able to afford it. This is more than 10,000 naira. So you look at the patient, you try to categorize and discuss with the patient. I want to do this test for you. This is the cost. So would you be able to afford it? Can I do that for you? And if the patient said yes, you want that test, you go ahead and do the test for the patient. But in a teaching hospital, it is compulsory. It's a teaching hospital. All the teaching hospital in Nigeria, it is compulsory that those three tests must be requested. While taking that sample for during that circulation in resuscitation, you take sample for those three things: full blood count, electrolyte and creatinine, which is a kidney function test, and urinalysis. Why do we have to do that? It is simple. It's a screening process. Some of the conditions will not give sign. For example, somebody with kidney problem, the person might not even know that the person has a kidney problem because the person might not have sign until the late stage of the kidney problem, when everything now will start to manifest. At that point in time, in some people, it might be too late to reverse the problem. So that is why in teaching hospitals, we do it as a routine practice that we have to take sample for those things so that we can screen for those conditions. So if we're able to pick anyone, we'll start at that early stage to treat the patient. So full blood count, we want to see the level of blood in the patient, if the patient is anemic or not. We also want to see if there's any feature of infection in the patient's body by looking at the white blood cell count. And urinalysis, we want to check for infection as well, urinary tract infection. We want to check for protein. If we check for protein, we see protein in the urine, it will tell us that either the kidney is having issue or the patient is having hypertension. So those are the two things that will give protein in the urine. Either the patient is having hypertension or there's a problem with the kidneys. So we do urinalysis to be able to pick these things. So we do full blood count to be able to check the level of blood in the patient's body, if the patient is anemic or not anemic. Check if there's anything suggestive of infection. And we do kidney screening tests, EUCR, electrolyte, urea, and creatinine, to screen if there's any kidney problem so that we can pick it early and prevent it from progressing. So after our diagnosis, we have our diagnosis. We are expected to have taken this routine 3 basic investigations, the urinalysis, the full blood count, the electrolyte and creatinine. But as I previously said, in a private hospital, you must individualize these 3. Speak to the patient and patient relative, tell them this is what you want to do. If they can afford it, you move on. If they said no, they can't afford it, you withhold it. Okay. So those ones are basic. But after this basic investigation, now that we sorted out in resuscitation process, we are going to request other additional investigation for the patient, depending on what our diagnosis is. A patient that has stroke, for example, we have to request investigations that will help us to confirm that stroke, and also to know the type of stroke it is. Is it ischemic stroke, which we'll talk much more at a later time, or is it hemorrhagic stroke? So we have some set of investigation that will help us to confirm that. So we have to write them down, request them. For example, we're going to do neuroimaging test for stroke. We're going to do either CT scan or MRI. After that, we're going to do carotid Doppler ultrasound of the neck. So after that, we're going to do chest X-ray, do ECG for the patient. So those are the additional investigation we are going to do for that patient. So after that investigation, the next thing is to give initial treatment depending on what the patient is feeling at that moment. So if the patient is feeling pain, we can give the patient paracetamol at that point in time. But there's something that is universal that you are expected to do. So that is the IV fluid. So we'll talk about IV fluid. And the contraindications. So in that sequence, we have taken brief history, we have resuscitated the patient, we have taken detailed history, we have done our examinations, we now have a diagnosis. We have requested for investigations, additional investigations, that will add to the ones we requested, the 3 we requested, the full blood count, the electrolyte and creatinine and urinalysis. Additional investigations, for example, in the case of stroke, MRI, Doppler ultrasound, to request those ones. So after that one, the initial treatment. So in that initial treatment, fluid is part of it. So in almost all the patients that present to the accident and emergency unit, we are going to give IV fluid. But there are some exceptions. So it is those exceptions that you are expected to know, so that you won't give fluid in people that have those exceptions. You won't have to give fluid in people that have those exceptions. Apart from those exceptions, other people you have to give them IV fluid. So what are those exceptions? Number one is any patient with heart failure. Any patient with heart failure, please don't give IV fluid. Don't give the patient IV fluid. Patient with heart failure, don't give the patient IV fluid. Number two, any patient with advanced kidney problem, any patient with advanced kidney problem, don't give the patient IV fluid. Number three, any patient with liver pathology, advanced liver pathology, any patient with advanced liver pathology. So you see, heart failure, don't give at all. In kidney problem, if it is advanced, don't give. In a liver problem, if it is advanced, don't give. So what else? Any patient with generalized body swelling, don't give the patient IV fluid. So those are the 4 contraindications to IV fluid. Heart failure, advanced kidney problem, advanced liver problem, patient with generalized body swelling. Don't give the patient IV fluid. So let's check out how we are going to, pick up these features. When to withhold IV fluid. So we're going to check that from head to toe. So we're looking at the patient head, we're looking at the patient head, we're looking at the patient face. Is the face swollen? Is the face swollen? We come down to the tummy. Is the tummy swollen? In abdominal examination, we saw pictures of ascites. Is that patient having ascites? Yeah? Is the patient having ascites? Is abdomen swollen? Is the patient having ascites? So look at the chest. We use our stethoscope. We listen to the chest, checking if there are features of fluid. There are features of fluid accumulation in the lungs. So when we listen with our stethoscope, we'll be hearing the sound we call crackle. We're hearing the sound we call crackle. So we're hearing chicky, 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 chicky. When the patient breathing, you'll be hearing chicky, chicky, chicky. When the patient breathe out, you'll be hearing chicky, chicky, chicky. So it tells us there's accumulation of fluid in the lungs. So we look at it. So the face, is the face swollen up? We look at here, use our stethoscope, listening to the chest. Are we hearing crackles, which are the chicky, chicky, chicky sound when the patient breathes in and breathes out? Then we look at the abdomen. Is the tummy swollen? Is the patient having ascites? Then we look at the leg. Is there any pidgin edema? Is there any edema on the legs? Is there any edema on the legs? So when we pick these features, it's telling us that it's either there is heart problem or there is either an advanced kidney problem or there is an advanced liver problem. So the patient is retaining fluid. So in that cases, we should not give the patient IV fluid. So those 4 conditions, heart failure, advanced kidney problem, advanced liver problem, generalized body swelling from any other cause, we don't give the patient IV fluid. So know those 3 and try to look for them before you give IV fluid. Check the patient face, listen to the patient chest with a stethoscope to know if there are crackles, which we pick as the chicky, chicky, chicky sound when the patient breathe in and breathe out. Look at the tummy. Is tummy swollen up? Is there ascites? Look at the leg. Is the patient having edema, pedal swelling? So when you pick those features, don't give IV fluid. Other than that, in other conditions, you can give, you safely need to give IV fluid in them. Give the IV fluid. Initial fluid resuscitation is very important. So it goes for all the patients that you are going to manage. As long as you're able to rule out that there's no heart failure, there's no advanced kidney problem, there's no advanced liver problem, the patient is not having a features of a fluid overload or fluid retention, give the patient IV fluid. So that is the next thing you want to do to resuscitate the patient. So we now have to talk about the two types of IV fluid. We have the colloid and we have the crystalloids. What is the difference between these two, colloid, crystalloid? So you need to get used to know this. You need to get used to it. So what is the difference between colloid and crystalloid? Well, the difference between colloid and crystalloid is the fact that colloid is more of a thick fluid. Colloid is a thick fluid. It contains a lot of proteins in them. So there are so many proteins in them, and there's so many proteins in them, or so many carbohydrates in them that make them to become thick. So they are thick fluid. But crystalloid are light fluid. They're light fluid. They're more of water with electrolytes, water with electrolytes, water with sodium, potassium, sodium, potassium, magnesium, bicarbonate. That's it. That's what a crystalloid is. But a colloid is a thick fluid with a lot of proteins or a lot of carbohydrate molecules. So that's the difference between colloid and crystalloid. So colloids have special indications. So we don't use them on routine to resuscitate a patient. No, they're not part of the fluid that we have to use to give the patient to maintain fluid balance. No, we don't use colloid. So they have special indication. For example, an example of a colloid is human albumin. When we use human albumin, we use human albumin in a patient that has hypoproteinemia. You have low level of protein in the blood. That's when we have to give the patient human albumin. So human albumin is a typical example of a colloid. It's a thick fluid with a lot of albumin, a lot of protein. And the form of protein there is albumin. So a patient that will have that has feature of hypoproteinemia, those are people who give human albumin. Remember in our general physical examination that we said a feature of hypoproteinemia or hypoalbuminemia is fluffy hair. So if we pick that fluffy hair, the hair is fluffy. We say, oh, that this patient has low level of protein in the blood. So what do we need to do? First of all, we need to check what is causing this hair to become fluffy. So possible causes: liver problem or advanced kidney problem. So we now know, okay, that's liver problem or advanced kidney problem. As part of our investigation, the hair is fluffy. We need to check for total blood protein and albumin. I've checked for total blood protein and albumin, and it's low. So we need to discuss with the patient, SAMA, you will need human albumin. So we need to replace the protein. So we'll give you human albumin. So that's an example of a colloid. An example of a colloid. So it's thick fluid with a lot of protein or a lot of carbohydrate. But crystalloid is water plus electrolyte. And of course, you guys know the most common crystalloids that we have is normal saline. Normal saline, it contains 0.9% sodium chloride. Contains 0.9% sodium chloride. So that's the most commonest. You find it almost in all the accident and emergency unit. Then we have ringers and lactate, which contain, apart from sodium chloride, they also contain potassium. So also contain some levels of bicarbonate. So now have 5% dextrose, which can either usually come as 5% dextrose saline. And we also have 10% dextrose water, just 10% dextrose plus water. So these are example of the difference between a crystalloid and colloid. So now let's look at this now. A fluid that we want to give can either be hypotonic. What does that mean? Hypotonic. What is tonia? What is tonia? The word tonic is coming from tonia. So tonia we want to measure the How do I explain that to you now in a very layman term? In Tony, I want to look at the concentration of this electrolyte in the blood, especially sodium. Especially sodium. I want to look at the concentration of sodium in the blood. Remember, guys, that the normal concentration of sodium in the blood is between 136 to 146 millimole per liter. 136 to 146 millimole per liter. That is the concentration of sodium in the blood. 136 to 146 millimole per liter. So I want to talk about tonia now. I want to look at the fluid you want to give to this patient. How much sodium does it contain? So if the sodium that the fluid contains falls between 136 to 146 millimole in 1 liter of sodium, we say it is isotonic. It's the same thing with what we have in the blood. But if the sodium content is less than 136 to 146 millimole per liter, we say it is hypotonic. So the tone there, or the tonia there, is referring to the sodium content of that fluid. What amount of sodium is in the fluid? That is what the tonia means. So if it is less than what we have in the plasma or in the blood, which is between 136 to 146, if it is less than that, we say it is hypotonic fluid. If it is the same thing as that, like normal saline now, if the sodium content in that fluid ranges between 136 to 146, we say it is isotonic. Iso means the same. There's no change. There's no difference. It's the same. Isotonic fluid. But if the concentration now in this fluid is higher, more than the sodium content in the fluid is more than 146 millimole per liter, we say it is hypertonic. If the sodium content is less than 136 millimole per liter, we say it is hypotonic. Isotonic is between 136 to 146, which is the same thing we have in the blood, 136 to 146 millimole per liter, isotonic. Hypotonic, less than 136, which is the lower limit of sodium in the blood, and hypertonic, greater than 146, which is the higher limit of what we have in the blood. So look at those fluid. Hypotonic solution or hypotonic fluid is 0.45 saline. When do we have to use this? Okay, guys, don't worry. I don't want to bug you too much. I don't want this stuff to be maybe too much stuff for you. So I won't be going into deep or details of this, but I just wanted to just speak some little points so that you know which fluids to give at each point in time. So hypotonic fluid is not routinely given. So we only use it, it's only the specialists that use it. People that are more specialized are the people that use it in some certain situations, some certain condition. So you, as at your basic level, you shouldn't use hypotonic solutions. Don't use them. So you can't use 0.5% saline. Don't use 0.18 saline. No, don't use them. And don't use hypertonic solutions. Don't use 3% saline. We can still talk about mannitol. We'll talk about mannitol when we'll be talking about stroke, the use of mannitol. Talk about them. So at your level, with your initiative as either paramedic or physician assistant, you can use mannitol. But we'll talk about the indication when we're talking about stroke. All right. So what do you need to use? You need to use isotonic solutions. Those are the ones you should use isotonic solution. Normal saline, the first line, you should use. Ringas and lactate is another one. So those two are your choice of fluid. But what should you use if you are generally given a choice to make? That is normal saline, that is ringas and lactate. At your level, put up normal saline. Normal saline goes with almost everything. You can give normal saline with almost everything. Ringas and lactate, you can also give it in almost everything, but you have to be careful, a little bit of careful in a patient with infection and severe infection anyway, not all type of infection, a patient with severe infection. So you have to be a little bit of careful because of the bicarbonate in the fluid. So generally, what is the fluid of choice? Is normal saline. Use normal saline for the resuscitation of the patient. And here we have some information on how the normal saline is constituted. What the normal saline constitute of. So having said that, would you resuscitate the patient? The IV fluid that you are going to give will depend on the level of the dehydration that the patient is having. The level of the dehydration will determine the amount of fluid that you are going to be giving. But in an adult with mild dehydration, or in an adult that is not dehydrated, I just want to maintain the IV fluid, you just want to give maintenance fluid, what you usually give is we give 1 liter of the IV fluid every 8 hours. 1 liter 8 hourly. So it means in 24 hours, the patient is going to get 3 liters of the IV fluid. So that's what we do for adults. That's what we do for adults to maintain the daily fluid requirement for the adult, for the patient. The patient comes in with stroke now. Stroke comes in with stroke that happened 6 hours ago. So after you have made this diagnosis that this patient is having stroke, you have requested for your investigations. Next thing you are going to do is put up IV fluid for the patient. Put up IV fluid, normal saline for the patient. How are you going to give it? 1 liter of normal saline every 8 hours, 1 liter 8 hours. So in 24 hours, the patient will get 3 liters of IV fluid. So, but in pediatric, it's a little bit different. We have to use the patient weight and be able to calculate the amount of fluid that we're going to give for the patient. So we're going to do that calculation for IV fluid regimen in the pediatric patient when we'll be taking some medical cases in pediatrics, some of the diseases, pediatric diseases that we're talking about subsequently. We'll be able to calculate the amount of fluid that we're going to give them using the patient weight and the daily requirement and how we're going to spread it. So that is it for this class now. Let's take question and see. So this page, this particular slide here is what we have to cover. Just an example of the fluid balance that we have in the body. So this is what you are expected to treat in physiology when you'll be taking your physiology class. So it said total body weight. So total body water. The total body water is 60% of our body weight. So it's a man that is weighing 70 kg, for example. Now that is the person body weight. So the expected amount of water, total body water that this patient will have will be 60% of that 70 kg. 60% of the 70 kg becomes a total body water that the person will have. And this slide is just telling us that intracellular fluid, which is within the cells, is about 40%. And extracellular fluid, which is outside the cell, the one we have in the blood vessel and the one we have within the interstitial spaces is 15%. Is 15% the one we have in the blood vessel is 5%. The one we have in the interstitial space is 15%. So if we combine two of them, extracellular fluid is 20% of the body weight. Intracellular fluid is 40% of the body weight. So that is what this slide is talking about. But you learn more of this in physiology. So just an overview of orientation before you now know the fluid and the type of fluid to give. So let's take question both from the let's take question okay, what is bicarbonate? All right, I'm going to answer that. I'm going to answer that. So I will use this opportunity to entertain question on the nervous system examination as well. The nervous system examination that we did, will I'll entertain question now, and I'll clarify any doubts that you guys will be having on nervous system examination. Okay, so the question is, what is bicarbonate? Okay. So bicarbonate, you don't really have to disturb yourself so much. It's not that it's not good. No, is fine. Just that in the body, anything that is too much becomes a problem. And anything that is too little also becomes a problem. So you must maintain a balance. There must be a range where it should fall. It shouldn't be too much. It shouldn't be too small. So bicarbonate is part of what we consider as electrolytes. We said when we are doing for kidney tests, when we are doing for kidney function tests, we want to look for the electrolytes. We want to look for urea. We want to look for creatinine. So bicarbonate is one of those electrolytes that we assess for. We have to check for the level. That includes sodium, potassium, chloride. Those are routinely done. Sodium, potassium, chloride, bicarbonate, urea, and creatinine. Those 5 are the 5 things we do when we send investigation for our kidney function test. Electrolyte, urea, and creatinine. So those 3 are the 3 routine electrolytes that we do. What are they? Sodium, potassium, chloride, and bicarbonate. So sorry, it's 4, not 3. Sodium, potassium, chloride, and bicarbonate. Those 4 are routinely done. They are part of the electrolyte urea and creatinine. They are integrated part, routine. It should be done. Sodium, potassium, chloride, bicarbonate. So we now have urea and creatinine, making the whole complete package as electrolyte, urea, and creatinine. Okay, so now the bicarbonate is a product of the respiration that we do. When we breathe in, we breathe in oxygen. So when the oxygen go through the process of metabolism, through the process of metabolism, the output is carbon dioxide. The output is carbon dioxide, CO2. So that CO2 dissolves in water. When it dissolves in water, when the CO2 dissolves in water, it gives bicarbonate. If you have an idea of chemistry, basic chemistry, you understand what I'm talking about. A CO2 plus H2O. CO2 plus H2O. That is the carbon dioxide, which is a metabolic product of oxygen we have breathed in. The metabolic product is carbon dioxide. So that carbon dioxide, CO2 plus H2O, that's carbon dioxide dissolving in water, will give us bicarbonate, which is a CO3H plus. That's the formula for bicarbonate, CO3H plus. That is bicarbonate. So it's a product of the carbon dioxide dissolving in water. It gives us that bicarbonate. So the bicarbonate is just a measure of acidity, the acid level in the blood. It's a measure of acidity, acid level in the blood. So when the CO2 dissolves in water, it gives us that bicarbonate, which is a measure of the acid level in the blood. So the normal range of bicarbonate, is between 20 to 28, depending on the lab. Some we say 22 to 28. Some lab will say 20 to 26. But generally, it's generally acceptable that any bicarbonate within the range of 20 to 28 or 22 to 28 is within normal range. But anything less than 20 coming downward, it means that the person is having too much of acid in the body. Person having too much of acid in the body. So low level of bicarbonate indicate acid. Low level of bicarbonate in the body indicate the person is having acid. The person is retaining acid in the blood. That's what we call acidosis. But high level of bicarbonate is called alkalosis. So anything greater than 28 is known as alkalosis. So the person is retaining bases. The person is retaining bases. So the blood will become basic. Blood can be either normal, basic, or acidic. Normal, basic, or acidic. When blood becomes basic, the bicarbonate level goes up greater than 28. When blood becomes acidic, the bicarbonate level goes down lower than 20. So that is it about bicarbonate, how it is produced, and what the values connote. Any other question? Let's take. Guys, question, ask your question, please. If no question, please indicate there's no question. Okay, if you can hear me, indicate that you can hear me. Okay, fine. So no question.